Good evening, everyone, and welcome to today's meeting of the Commonwealth Club of California, the place where you are in the know. We're online at commonwealthclub.org and also on Facebook, Twitter, and our YouTube channel. I'm Mark Zitter, chair of the Zedema Project, a member of the Commonwealth Club's Board of Governors, and of course, your moderator for this evening's program. We're going to talk about U.S. healthcare. U.S. healthcare is usually considered to be the best in the world. However, if you look at the objective measures of things like health outcomes, cost, and coverage, unfortunately, we're far from the top. This discrepancy between the perception and reality of the U.S. healthcare system is the focus both of tonight's session and also of the book that was recently written by our speaker, Dr. Robert Pearl, who is the executive director and CEO of the Permanente Medical Group and author of the new book, Mistreated: Why We Think We're Getting Good Healthcare and Why We're Usually Wrong. The book recently reached number 7 on the Washington Post bestseller list, so congratulations to Dr. Pearl on that. And I also want to mention that all the profits from the book, Dr. Pearl is donating to charity, particularly focused on helping people gain access to healthcare who don't have that. Yeah, that's what yeah. As head of the Permanente Medical Group, which is the nation's largest medical group, Dr. Pearl is responsible for healthcare for more than 4.8 million Kaiser Permanente members, both here in California and also on the East Coast. Selected by Modern Healthcare as one of the most powerful physician leaders in the nation, Dr. Pearl has published more than 100 articles in a variety of medical journals and also writes a regular column online for Forbes.com. He serves on the faculty of both the Stanford Medical and Business Schools and also has been a visiting professor at the Johns Hopkins School of Medicine, the Haas School of Business, and Harvard School of Public Health. He's board certified in plastic and reconstructive surgery and received his medical degree from Yale University. Today, Dr. Pearl will discuss why so often we don't get the best health care while usually believing that we do. He also will explore how we might address some of the biggest problems we have in our healthcare system, including, of course, excessive costs, poor quality, lack of convenience, and ultimately, he'll also discuss how we can transform the U.S. healthcare industry. Following his remarks, he will take questions, so please write them on the cards you found in your seats and pass them to the ushers, who will bring them to me. At this point, please help me welcome Dr. Robert Pearl.
Good evening. My father, Jack Pearl, was a remarkable man. He was the son of 2 immigrant parents. He worked his way through college and dental school. When World War II broke out, he could have stayed safely behind American lines, but he volunteered to join the 101st Airborne. He parachuted on D-Day. He and his troop were captured by the Germans. He led a daring escape through the forest in the middle of the night for 2 nights, brought everyone back to safety. He was truly part of the greatest generation, a true American hero. When he came back to the United States, he raised his family. He was one of the most energetic men, sleeping 5 hours at most at night, till one day he got tired. He went to the doctor, and the doctor diagnosed him as having a hemolytic anemia, which meant that his own body's breaking down the red blood cells in his body. The organ that breaks them down is the spleen. It's a filter, and the physicians took out his spleen. The spleen is particularly important, however, at helping the body fight a particular bacterium called the pneumococcus. The pneumococcus has a shell around it that makes the usual immunologic responses difficult, and the spleen helps protect the body from systemic infection. Every physician in New York, where he lived half of the year, knew he needed a pneumococcal vaccine. Every physician in Florida, where he lived the other half of the year, knew they needed a pneumococcal vaccine. But the physicians in New York assumed the ones in Florida had given it to him, and the ones in Florida assumed the ones in New York had given it to him. And primary care thought specialty care, and specialty care thought primary care, and in the end, he never received the vaccine. A couple of years later, he was visiting my brother and myself, and after a wonderful dinner, he went to my brother's house in Palo Alto. My brother's chairman of anesthesia at Stanford. My brother, on the way to rounds in the morning at 5 a.m., found my father on the floor, unconscious, unresponsive. Called an ambulance, rushed him to the ICU, where he spent 4 days unresponsive, unconscious. 3 weeks in the hospital. He survived the acute event, but never the complications that developed from it. He died from pneumococcal septicemia, a preventable medical error. He was simply one of 200,000 people that year who died, who simply didn't need to. The American healthcare system is broken. It most closely resembles a 19th century cottage industry. It is fragmented with doctors spread out across the community, hospitals located in every single town. It is paid on a piecemeal basis. We call it fee-for-service. The more you do, the more you get paid. Whether it does any good or not is irrelevant. The technology most doctors use is left over from the last century. It's predominantly designed around billing and coding and collection. And the consequences of the broken system are obvious. We spend 50% more than any nation on the globe, and our outcomes are in the lower half of the 20 industrialized nations. A girl born today in Seoul, Korea has an average life expectancy of 90 years. The same girl in the United States, 7 fewer years. We're last or second to last in life expectancy, last or second to last in childhood mortality. So many Americans simply accept less in their health care than they would take in retail or banking or travel. They'd never fly in an airplane if they couldn't make online reservations, but most patients in this nation have to call a doctor's office Monday to Friday, 9 to 5, to make an appointment. They would be unwilling to bank or use a financial advisor who did not make their financial information available to them. But if their daughter's going to kindergarten the next day, they have to drive to the doctor's office to pick up the form or find a fax machine someplace. You can't email your doctor, you can't do video. That's the state of American medicine. 500,000 people die every year unnecessarily. They die from failures in prevention. They die from chronic disease, from complications that could have been avoided, or they die from medical error. My father, Jack Pearl, was one of them. But ask Americans about the medical care we provide in this country, and they'll say it's the best in the world. Bar none. Maybe a little expensive, but the best in the world. And there's this dichotomy, this contradiction between what people perceive and what the objective data says that led me to research and write and publish Mistreated, Why We Think We're Getting Great Health Care and Why We're Usually Wrong. I looked at the psychological literature. Many of the experiments are pretty old because today would never pass an ethics committee because of the psychological damage to the participants. I looked at the most recent brain scanning literature. And what I saw was a pattern. Context, shifting perception, changing behavior. Think back to college. You study the Stanford Prison Experiment. Philip Zimbardo takes normal students. Half of them he assigns to be jailers. He gives them aviator sunglasses. The other half he assigns to being jailees. They get OR shirts and numbers. Within 48 hours, the jailers see the jailees as being dangerous. They inflict debasing punishment upon them. The jailees see the jailers as being sadistic. They board up the doors. Everyone in that experiment knows the other person's a student. But context shifts perception and changes behavior. A more recent example is Joshua Bell. Joshua Bell is a virtuoso violinist. On Saturday night, one time in few years ago, he always plays with the Boston Symphony, but he played a concerto in the Boston Symphony. Probably earned about $5,000 or $10,000 for his work. And Monday morning, 2 days later, he went to Washington, D.C., went down to the Metro, dressed in old clothes and a baseball cap. He took out the same violin, he played with the same virtuosity, and in 43 minutes, he earned $34. 99% of what you pay for when you go to the symphony is simply context. The music was exactly the same. The outcome was different depending upon if you were sitting on that podium or down in that metro. Colleagues of mine at Stanford did the following experiment. They put people into brain scanners and they asked them to compare 2 glasses of wine. One was poured from a $50 bottle, one from a $5 bottle. What the participants didn't know is the wine was exactly the same in both bottles. Now you might guess, people are laughing a little bit, you might guess that the people would say the $50 bottle was better, which they did. But the brain scan was what's most interesting because the reward center of the brain lit up, was activated dramatically more for the $50 bottle than the $5 bottle. 99% of the wine we drink, the price we pay, is the bottle. Not the nose, not the taste, not the olfactory. Context shifts perception that changes behavior. I personally believe, and this is the one part for which I have no real evidence, but I have a hypothesis, that actually derives from a long time ago. Remember, evolution happens over a long, long time period of brain evolution, but technology happens fast. And I imagine 30,000 years ago, if I had to convince Mark, the host, to go kill a woolly mammoth with me, he'd look and he'd say, "You're out of your mind. It weighs 10 tons, it's got these long tusks." But what I would know is that if we didn't go and attack that animal, we wouldn't survive the winter. And so our brains develop this ability to be able to change perception. And when you actually look more at the literature on the subject, what you see is that in times of great reward or times of great threat, the parts of the brain, the reward center and the amygdala, become activated, and within fractions of nanoseconds, the perceptual parts of the brain change as well. We actually change what we see. And this is very relevant to healthcare because healthcare is about reward and fear on both the physician's and the patient's side. Now, the book has probably 30 different anecdotes, and they're all very interesting and sort of fun because they're all the ways that we behave in strange ways. But I thought I'd give you 3 just to give you a sample of what I'm talking about, to understand the impact of context of the American healthcare system on the care that is provided to people in this country. Now, you may not want to know the fact that I'm about to give you. 1/3 of the time, when physicians go from hospital room A to B, they don't wash their hands. It's been studied hundreds of times. Now, every physician has taken the classes, they're mandatory, that explain how hospital-acquired infections, by the way, one of the leading causes of death in hospitals today, happen. The bacteria, particularly the most common and destructive one, it's called C. difficile, is actually carried. It doesn't go in the air. It's carried by people. Someone is carrying bacteria from one room to the other, and everyone is certain that it's not themselves. It's just as impossible as the Zimbardo study, but it's just as real. Someone is carrying it. So what happens? Doctor's late. Doctor has to get to the office. Doctor has an extra patient, whatever it's going to be. Reward or fear, it could be either or both. And the perception changes. I want to be really clear about this. Doctors are very mission-driven, ethical, moral people. They're not going to do anything to harm a patient. But when that perception changes, they're convinced they're not carrying germs. There's no scientific, logical reason for it. That's just the way that our minds work. I'll give you another example. This is a local one. So we're in San Francisco. And between San Jose and San Francisco, there are 10 hospitals that do heart surgery. 3 of the hospitals do fewer than 300 surgeries a year. That means, by definition, at least 65 days a year, the team comes in and does nothing. Now ask yourself, how can you get great quality? And you certainly can't get efficiency of performance. Take any of the hospital administrators, put them in my class at the Stanford Graduate School of Business, and every one of them will get the right answer. Take the 3 services, combine them, you'll have a much higher volume. Quality will go up, costs will go down. Ask the administrators today, not a single one will tell you it's a good idea. When you're afraid to lose your job, when you see the rewards of the economics, it changes your perception, it changes your action. It's not bad people, it's a bad context of American medicine. I'll give you one other example. You may remember that after President Clinton left office, he developed some cardiac problems. And you may remember that his wife was the senator from New York at the time, and so they were living in New York. And the state of New York publishes an examination of all 35 heart surgery programs in the greater New York area. They risk adjust it, they rate it. It's very easy to find on their website. You can be sure that President Clinton, remember he led a lot of the healthcare reform efforts in the early 1990s, had access to this database. When he developed his heart problems and needed to be evaluated of diagnostic catheterization, he went to the hospital that had the second worst outcome in all of New York. When he then needed surgery, he went to the one that had the worst outcome in New York City. And guess what? He suffered a major complication. Now, what's interesting about that to me is not that it happened in that way at that particular time, because who knows, maybe he thought it was an emergency, maybe he didn't think to check. But 6 years later, when he needed to have repeat surgery on the complication, guess where he went? The worst hospital one more time. That is how the context, and I don't know if it was a friend of his who suggested it or a colleague or whatever it was, context changes perception, which changes behavior. So in looking at Mistreated, what was really most interesting to me was, well, these stories were interesting, but the more interesting part was, if context can shift behavior in negative ways, maybe it can shift behavior in positive ways. How can we use context to change the American healthcare system? And that was my goal in writing the book. And I, over time, developed a roadmap for the future. And within it, it's built upon 4 pillars. And each pillar is important because each pillar is not only operationally more efficient, but each pillar changes that perception. The first one is integration. Horizontal integration within departments and vertical integration between primary care and specialty care, outpatient care and inpatient care. When care is integrated in that way, when you have 7 physicians instead of 7 ones, what you end up having is easier access for patients, lower cost, more specialization, much better quality. But what you also shift is perception. Because now these physicians are no longer your competitors. They're now on the same team. And when you're on the same team, you're sharing information, what happens? Collaboration, cooperation, coordination. Healthcare is simply better when it's integrated than when it's fragmented. And when you pay people, the second one, not on a fee-for-service basis, but a pay-for-value, some variant of capitation. Not only is it better because it aligns the incentives of doctors and patients, but more importantly, it changes perception. Suddenly, prevention becomes more important. Suddenly, avoiding complications from chronic disease becomes more important. Suddenly, the ability to avoid medical error. And then when you give them not a technology from the last century, but a comprehensive electronic health system, a system that has all of your information and presents it at every point of contact, and you do it in an integrated, prepaid way. Now all the physicians want to work together as one. Using that data, specialists are going to be looking at the issue of how do we prevent disease as much as primary care. And then finally, physician leadership. Doctors simply are not going to follow hospital administrators or insurance executives. They don't trust them. But they will follow physician colleagues who have been well trained in physician leadership and are able to make the changes happen that are so necessary. And when you look at organizations that have these characteristics, what you see is they perform higher than the overall community. Across the United States today, hypertension is controlled 55% of the time. In these organizations that have integration and capitation, advanced information technology, and physician leadership, they do it 90%. And colon cancer, half of the colon cancer deaths in the United States are preventable. And in general, it's about 50%. These same organizations do it 90%. And when you put it all together in the area of cardiovascular disease, which is far more complex, they lower the mortality 30% below the rest of the community around them. That opportunity to understand the power of each of these four pillars is crucial. So I wrote Mistreated for my father, and I wrote Mistreated to change the health care of patients across the United States. But I also wrote it to save the professionalism of medicine, the professionalism of being physicians. Because it's under attack today. It's under attack today by all the pressure being brought to bear, by all the ways the physicians being squeezed. Burnout is a very common phenomenon. A third of physicians report being depressed. There are 400 suicides every year. Half of physicians tell their children don't become doctors. And the beauty of the things that I talked about, working on a team that's paid for value, not for volume, that has the information you need and has the leadership you required, I think is an opportunity to be able to save the professionalism of medicine, the role of being a physician. I think there's only three paths that we will follow. I can't think of any others as a nation. One, and the one that obviously I wrote the book for, I wrote Mistreated, and the one that I recommend is that we transform the delivery system. Right now, the debate in Washington, D.C. is over coverage, and the coverage debate is a very important debate, because without health care coverage, you can't get great health care. But no matter what happens in Washington, D.C., it won't matter if we don't change the delivery system, because the cost of care will simply rise so fast that individuals and businesses and the government can't afford it. Today, the out-of-pocket expense for 40% of Americans is now approaching $5,000. They can't afford to pay that year over year. The businesses can't, and right now 40% of the government expenses, tax revenue, goes to paying for health care, and 10,000 baby boomers are becoming Medicare eligible every single day. We have a crisis that is coming. And if we don't change the delivery system, it won't matter, although in the short run it matters very, very greatly. The second thing that might happen is we're simply going to devolve into a two-tier system. And today we have a two-tier system. The poor do not get the same care as everyone else. But I'm talking about a two-tier system where the middle class can't get access, where senior citizens on Medicare can't get access, where the only people who can get access are those who are willing to buy, can afford to buy additional private insurance. And we're going to see eroding of the traditional values of American medicine. And the third possibility, and it's happened to a lot of other industries, just ask Kodak, just ask Borders, is that we're going to see disruption. That the traditional way of approaching and solving problems simply disappears. And I have colleagues who believe it will come from the American technological areas, the Googles, the Facebooks, the Amazons of the United States. But it well could come, as it has come in other industries, from offshore. I have a friend named Devi Shetty. Devi Shetty runs 11 heart hospitals in India. He was Mother Teresa's personal doctor, so he's a pretty well-respected individual. If you ask Devi, what do you do? He says, I set a price on human life. You say, Devi, what do you mean? You're a heart surgeon. What do you mean you set a price on human life? He says, every morning I come to the hospital and there are 30 moms carrying 30 babies. They've all been well worked up. They all need surgery. I chat for a couple of minutes, and then I explain, because 90% of people in India do not have insurance, what it's going to cost. If the family can borrow the money, the child lives, and if not, the child dies. Today, he does heart surgery for $1,800 a case. He says, if I can get it down to $1,500, I will have elevated the price of a human life because more children will live than otherwise might. I don't think people are going to travel to India to get the surgery done. But Debbie also built the hospital that he opened 2 years ago in the Cayman Islands. Now, I'm even to the Cayman Islands. They are beautiful. 7-mile white sand beach, tourist economy, great weather. The hospital will have 2,000 beds on an island of 50,000 people. 20 of them will be taken up by Cayman Island folks. It's a 1-hour plane ride from Miami. And I believe that Devi would like to be the solution to the American healthcare. Today, he does heart surgery for half the price of the United States with results that are only slightly better than the leading heart institutes in the United States today. When I visited him in India last Thanksgiving, his team did 37 heart surgeries that day, including a heart transplant. That's more than anyone outside of Kaiser Permanente does in Northern California in a month. Volume like that, your quality is pretty good, your costs start to come down dramatically. I don't know what's going to happen to American healthcare. I worry about it. That's why I wrote the book every morning from 4:30 to 6:30, often late at night, because I think that the American healthcare system is broken, and that if we don't change the context, if we don't move from fragmentation to integration, from fee-for-service to pay-for-value, from the technology of the last century to the technology of today, and if we don't move from it being led by administrators to physicians, it will collapse, and we will regret it. And I'm hoping that together we will avoid it. I wrote Mistreated for the patient in all of us, and I hope that all of you will demand more in your health care in the future than you have in the past. Thank you very much.
Thank you, Dr. Pearl. You're listening to the Commonwealth Club of California, and I want to thank Dr. Pearl for his remarks. We are now going to take some questions. Thanks for those of you who sent them up. It's not too late. You can send up some more if you like as well. I am going to start take the first question of moderator privilege. You've talked about how important it is to change our beliefs and our behaviors in healthcare, both on the doctor and the patient side. And you've also pointed out, I think rightly from my perspective, how hard it is to change beliefs and behaviors. So we want to do that for doctors and patients. If we have to choose a priority, are we going to get more traction working on the doctors first or the patients first?
Definitely the patients. I think that what I call Mistreated, the legacy players, the hospitals, the physician organizations, the drug companies, the insurance companies, they don't want to change. And it's not that they don't want to change because they are bad people. They're like all the rest of us, and that's the point of the book. It's not about vilifying individuals. It's about how that context changes the perception. And it's just that much harder to be able to change when you're very successful today. And all those groups are very, very successful today. But it's the patients, the people in the audience here are the ones who are having the problems paying for their medical care, the out-of-pocket expenses rising, paying for their drugs, the cost going up at 6 times inflation, 3 times the rest of healthcare today. And I believe it'll have to be the patient in all of us that is going to be the one to demand that change, who says, I want to be able to email my doctor. I want to be able to do a video visit. I don't want to have a complication. I want to know my doctors are talking and coordinating. And if I can't get it from you, I'm going to go someplace else. So when that starts to happen, I believe that American healthcare will change before the crisis.
Okay, so thank you. There's a number of questions here. I'm going to try to combine a few. So I promise I will not be able to get through all of these wonderful questions. I'll warn you that from the start, but I'll try to pick the ones that I think are going to be the ones that will be the most interesting for this group. There's a few about visits, particularly at Kaiser, in terms of the average number of minutes a doctor has with patients, the challenges of having to get as many patients through primary care as possible, and what can be done about that, what's optimal there. And I guess a question I'd say is related is also, why doesn't Kaiser publicly report individual physician quality metrics?
So I'll take the question on Kaiser, although I do think that the book is really about the nation and less about any particular institution. So our average primary care physician sees between 15 and 16 patients a day. Now, not all the time in their day is going to be specifically allocated to patients because they have telephone or in-person visits. They have telephone calls and things they do on their computer. But that's the average today. So if you want to do the math, it's somewhere around 30 minutes on the average per patient that they theoretically could spend providing that care. The other half you asked me, Mark, was?
Oh, just about quality metrics.
Oh, the quality
reported
metrics.
individually.
Yeah. The reason is that the individual metrics are very much impacted by who you take care of. So if you take care of really sick people, your results aren't going to be particularly good. But that's very hard to realize unless you do the analysis. The analysis we call risk adjusting is exceedingly difficult to do. Similarly on satisfaction, we see tremendous variation by ethnicity, by age. And so there's a lot of factors that impact any individual. And it's why in the book I say it's not about who the best doctor is. It's really about what's the best system of care, and are they coordinated, collaborative, sharing the information, able to refer one patient to another. A great example to me, I was walking down steps at the end of January. It was a rainy day, and a gentleman above me slipped and fell and crashed into me and broke my leg. I went to one of the Kaiser facilities, and I saw a surgeon that I knew, and he said, "I'm happy to do your surgery. But there's a guy better than I am at the Kaiser down in San Jose at your particular operation." Now try to think how amazing that is for one physician to send to another, but that's the context that existed. And of course, the best part was, rather than having to see him, I did a video visit and then met him on the day of surgery, avoiding the discomfort and the pain that happens in the transportation that sits in place. You know, I'm not here to talk about Kaiser Permanente as being the answer for the whole nation. I think there's a lot of other groups, the Mayo Clinics, the Geisingers of the world, that are organized in the same way and equally provide excellent care going forward. In fact, quite a number of them was called the Council of Accountable Physician Practices, CAP, that I serve as chairman for. But I think that the systems of care, the ability to get all the things treated at a single visit, the ability to align the interests of the doctor and the patient are what is necessary for this country. Some places will be a Kaiser Permanente, some places will be a Mayo Clinic, some places will be virtual. But in moving from fragmentation to integration, fee for service to pay for value, old technology, new technology, I believe that we can and will change healthcare for the better for all Americans.
Great. Got a couple questions here that fall onto the issue around healthcare quality, and some of them are systems questions. So one was, what is your opinion on why Debbie's quality is so good? I assume it's more than just the individual. Another question about the checklist manifesto and that approach that Atul Gawande talks about, and how's the best way to get clinicians to adhere to those checklists, whether incentives, reminders, or metrics, or so forth. And finally, related to is about medical errors as a potential learning tool, but also challenged by a culture of silence and protection. So I'm going to put those all into one question about medical quality. You've led a lot of doctors. You know some things about this.
Well, let me start with the issue of why Debbie's quality is so good. It's because of the volume. When you have high volume, your whole team gets used to doing procedures. You become simply better at doing it. I don't care what it is you're doing. Whatever your job's going to be, you do it more frequently, you're going to get better at doing it. As you start to have higher volume, you also get specialization. A good example to me of that in the United States is minimally invasive surgery. So for women who need to have a hysterectomy, there's two ways to do the operation. You make a long incision down the abdomen, which means you now have to be in the hospital for several days, and it takes about 6 weeks before you can even lift anything heavier than a shoebox. Or you can have it done through a laparoscope, actually two, like telescopes that go inside the body, in which case you tend to go home the same day, and you're often back to normal activity within a week or 10 days. Across the United States today, let me back up even a little bit before that. I asked the OBGYN physicians, I said, if you're about to have surgery, how many of these procedures would you insist that your attending physician have done last year? You personally. And they all said somewhere around 25 to 40. Half of the physicians in the United States today do fewer than 10. Half of the time, they do it with an open, big abdominal incision. Not because it's medically needed, because that's simply the thing they know to do. In Kaiser Permanente, as an example, 95% of the time it's done through laparoscopes by individuals who have a volume that's high enough to be able to justify all of that. The challenge is making that happen. Doctors don't like to give up the occasional rare operation they get to do. And so making that change becomes so essential. And it's just as true for cancer surgery. It's just as true for almost all the procedures that are being done. And that's where I think the big advantage is. I also think that it's essential that we understand how long it takes for change to happen in healthcare. And the story I love comes from Australia. It's a gentleman named Barry Marshall. Barry Marshall was a pathologist. And in looking at specimens, and I talk about this in my book a lot, in Mistreated, he saw that in patients who had ulcers, this particular bacterium, the H. pylori, was often associated with the particular ulcer. And so he published this, expecting that physicians across the world would embrace the notion that maybe ulcer disease wasn't stress, and it wasn't rich foods and spicy foods, it was actually this bacterium. No one wanted to change. He then there's a gentleman named Dr. Robert Koch, who was the father of microbiology. He lived in the late 1800s. He came up with called 4 postulates, the way you prove that any disease is etiologically tied to a particular bacterium. He did it for anthrax, he did it for tuberculosis. So imagine this. Dr. Marshall starts by taking a scope and looks in his own stomach, shows that it's normal. He then takes a petri dish and drinks the bacteria from a patient who had the disease, rescopes himself and proves that he's now created an ulcer. He now takes the antibiotics and rescopes himself and shows that he's cured himself. It's the most definitive demonstration of the Koch 4 principles. And 15 years later, 2/3 of physicians in the United States are still treating it by resecting the stomach and not giving antibiotics. It only changed when Marshall won the Nobel Prize for medicine, at which point now it took 15 years to go from what was really a great idea to full practice. The RAND companies showed the same thing. What we know is that there are better ways to do it. The manifesto around quality that Atul Gawande has pushed quite a bit cuts the mortality in half. Physicians don't like it. Why is that? They don't like to be told what to do. They think they're impervious to error, but someone sometimes cuts the wrong leg off. It just can't be them, because that's how context shifts perception, changes behavior. What the manifesto does is allow everyone to make sure they do it the right way and to let every voice speak up, because someone might see something that's wrong. Near misses, the airline pilots have demonstrated for a long time. They're the best learning tools. You want your pilot not to make a mistake, but you want them to be able to admit the mistakes so that they and others can learn from those mistakes. And that's medicine. It just goes so opposite the medical culture. Doctors are trained to believe they are infallible. They're trained to believe that their subjective belief is better than the objective data. It doesn't make any sense. Medicine is scientific. Occasionally, we don't know what to do. Or occasionally, there are competing priorities. But most of the time, we know, and we just don't do it. That's why that hypertension control is 55% and not 90%. What we know is that screening people for colon cancer would cut the death rate in half. There are 2 ways to do it. You can do colonoscopy, or you can do what's called a FIT test. Privacy of bathroom, 5 minutes, no bowel prep. How many of the GI physicians are encouraging patients to have the cheap alternative? And how many patients are having nothing done as a consequence? And how many people are dying? and what's happening to their families. Mistreatment, I'll say again, is not a consequence of bad doctors, poorly trained doctors. They exist. Or greedy administrators or drug company CEOs. Context changes perception, changes behavior, and unfortunately often changes it at the expense of patient care.
You have some questions here about the notion of paying for value, or they kind of circle around it, so I think this might be an opportunity for you to clarify that a bit. One question is, how does the U.S. begin to place value on procedures and treatments such as, like other countries that like France do, where the cost of care is less? And a related question is, what role does the patient have in deciding the value of a healthcare treatment they receive?
So when I think of pay for value, I think of it as being quality, but I also think of it as being personalized service and access. So the patient is very much at the forefront of that because they're the only ones who can judge how the service was, whether the care was what they wanted. They may not have wanted care for 2 months. They might have care in 2 days. Did they get what they wanted? So the patient is very much, I think, involved in that. And I think the difficult conversations around what patients want or don't want, which may not be what the physician would like to do, but it requires that we take the time and invest the time. So I think the pay for value has to be focused on the individual, their preferences, as well as their medical needs and conditions that sit there at the same time. The challenge of pay for value is, how do you measure it? And right now, for the physicians in the audience, you're well aware the government is putting in place a set of programs. It's called MACRA, MIPS. There's a lot of abbreviations that sit in place. And the problem, it's just very, very difficult to do. And it's why, again, in Mistreated, I talk about this evolution that has to happen. We have to get beyond pay for value to actually creating these pillars, that integrated pillars that simply change the context and people collaborate and cooperate in ways they don't today. We're shifting how we pay people, so all of a sudden they're rewarded for those better outcomes. They don't have to measure it every day in a different kind of way. It's just too time-consuming and problematic. It's that opportunity to be able to shift the perception. Milgram demonstrated that under the right context, he could get normal people to give a lethal shock 2/3 of the time to someone they didn't know. If he can do that, why can't we change American healthcare?
Great question, great question. All right, I've got two different questions, very different, that I'm going to pair together just because I'm the moderator and I can. And, but I think you'll see where they're sort of related or maybe mirror images. The first is, how have your Kaiser colleagues reacted to the book, and has it prompted any changes? And the second, which is sort of the mirror image in a sense, is if you were to lead a fee-for-service system such as Sutter, what major changes would you make? That's why we pay him the big bucks, right?
So my colleagues in Kaiser Permanente have enjoyed the book a lot. I've had the chance also to do radio and TV and talk about it to parts of the country that really don't know about integrated care. I mean, in California, we have a lot of systems, but in many parts of the United States, they have never even seen what an integrated system starts to look like. I think they're very proud of the outcomes. You know, there's 1,000 programs that the National Committee for Quality Assurance looked at, and Kaiser Permanente Northern California was the only one to get a 5-star rating for both commercial and Medicare. So they're very proud of the book and very proud of the direction. And I think the people in the Sutter system have a lot of the same characteristics in terms of being, in many ways, integrated and collaborative with a lot of the same technology that sits in place. And so I'm not sure I'd want to give anyone else advice about what to do beyond that, which I say in the book, which is I think that everyone in this country needs to move in that direction. And I believe that if they do it well, they actually can save hundreds of thousands of lives every year and lower the cost of health care. It's not one or the other. You know, I had an opportunity a couple of years ago to be in the Oregon Health Sciences building. And I saw a sign. This was the late 1990s. But it's a sign I'll never forget. Across the top, it said quality, service, cost. And the bottom, it said, pick any two. That was the mindset of the past. It can't be the mindset of the future. I think what we have to understand is that in working together, and it may be very painful. It may mean consolidating hospitals, consolidating services. It's going to mean we need to train more primary care physicians and fewer specialists It's going to mean we're going to have to increase the volume so people have the expertise. It means that some people simply won't be able to do things that they would otherwise like to do because the consequences of allowing it to continue, that's why I chose the title of the book, Mistreated, is there are people who will have negative consequences. They'll get complications. People will die. Mothers, fathers, parents, children, unnecessarily. And I think when we start to see that, shift the context from looking at it as how do we make it physician-driven or office-driven or traditional model-driven and move into one that is more aligned for the future, that we will save lives, and when we look back, we will be glad we went there. But getting people to have that courage, making that shift, is going to be difficult.
Right. This is a good time for me to remind everybody that you're listening to the Commonwealth Club of California. Our guest today is Dr. Robert Pearl, Executive Director and CEO of the Permanente Medical Group, who's discussing how to improve the American healthcare system. I'm Mark Zitter of the Zedema Project. You can catch up with the Commonwealth Club programs on the radio and on the club's YouTube channel and Facebook and Twitter. Next question. I'm going to combine a couple here again, but they'll be a little bit closer than the other one. Really, it's about the role that medical education might play in helping to solve some of our problems, and related to that, how do other health professionals fit into your vision for improving healthcare?
So in terms of education, I think that we need to do a much better job of training people, particularly training physicians, because they don't really learn in medical school how to do the things that are necessary to help to create the teams, because it leads to the second part. Because this is, although I speak a lot about physicians, I speak about that because I think it's the first mover force. But the care is provided by teams. The reason why Dr. Shetty gets great results is also the nurses who have a lot more experience, and those facilities that have higher volume get that. The reason why patients today can often have outpatient total joint surgery is because the physical therapist and the patient educator and all of the other clinicians on the team are able to contribute in ways to ensure the optimal experience. So I think that increasingly what we're going to see is that medicine is going to be a team sport, but it's got to start with the patient. And it has to start with what are the objectives, and that's going to be the highest quality, avoiding the medical errors, ensuring that we do prevention at every given point, ensuring that we have enough volume being done by everyone, ensuring it's being done in facilities that have enough volume that people have the expertise. And when you put all those pieces together, I know that we could save 500,000 lives every year while lowering the cost of medicine for the American populace.
There's a few questions from patients, and at least this one probably is not a Kaiser member because of the nature of the question. It says, what specific action can we as patients take to ensure that we get better care? I'm guilty of delaying care because it's so hard to find a doctor or specialist in my network to pay with no idea up front of what it will cost. And a related question there is, how do we as patients help shift care from disease-focused care to more wellness-focused care?
I think this is the fundamental part of Mistreated, because I think the only way you can do that is to get care someplace else. You're not going to be able to force those physicians to offer you the video visits or offer you the opportunity to send a secure email or offer you, or have the confidence that they're going to focus on all those preventive pieces without the information from a comprehensive record. It's not that they don't want to do it. It's just that they can't because they're stuck in the system that is not going to pay them unless you come to their office. They're stuck in the system that doesn't allow them to have the linkage with all the other physicians in the community that give you the choices that you want. And so I think it's going to happen because people move from one place to another. I also believe in the audience, obviously, there are a lot of business people, that the businesses are going to have to demand it. If healthcare costs keep going up at the rate they're going, they're going to make American businesses simply less and less competitive globally. And so we're going to have to find the way, and I would hope, and I would encourage people, in this week's Forbes blog I write about, that I think that businesses should say that at a certain time in the future, let's say 5 years from now, we're only going to buy insurance from organizations that are organized and integrated, that we can pay in a capitated way, that have the technology and the leadership that's required. So I think it is a difficult part. That's, again, why I wrote Mistreated for the patient and all of us, because I think the patient's going to have to demand it. And when they can't get it in the system they're in, they are going to have to move to another system. Now, other parts of the country are different because there are no choices. And there I do believe, and part of the job I would hope to lead nationally, is that opportunity to create those systems inside the dysfunctional, disorganized, fragmented group that's out there. I think it can get done. It's just going to require that our nation demand it.
Okay. Well, that leads to another question you and I talked about prior. I'll admit my wife and both of her parents had been Kaiser doctors. Our family has chosen Kaiser, even though we had many different choices, because it's a real system. And when I go into a Kaiser office, the first thing I see when I give them my card is which drugs I'm on, a list of all the tests I should have had, which ones I've had, when they're due, things like that. Things that are incredibly unimpressive compared to any other industry in America, but very impressive compared to other parts of the U.S. healthcare system. It's crazy. Kaiser's had a lot of success in terms of its growth. It's had a lot of success in terms of its quality metrics. And the obvious question comes up, why don't we have the Kaiser model elsewhere? I happen to know Kaiser has tried to replicate elsewhere with very limited success. Why can't we move the Kaiser model to other parts of the country easily?
It has to do with how difficult it is to take the fragmented system and integrate it. I mean, think about that. You have to take physicians who've been used to working alone and get them to start working together to create a team. They all have individual electronic health records. You've got to get those records to come together. You need to now change the way you pay physicians. You know, one of the things as you talk about pay for value that strikes me is that everyone in this room would value avoiding a stroke more than having an interventional radiologist go in and pull out the clot or insert a stent into your vessel, right? And how do we pay doctors? We pay doctors who pull out the clots a lot more than those who prevent in the first place. Everyone in this room would rather avoid a colon cancer in the first place than go on chemotherapy that's could probably be pretty expensive and may extend your life by a few months. But read the media, what do they talk about? All the new drugs, not about the gaps in care. Many of you in this room, not all of you, would like to have your care without having to go to the doctor's office. Just the appropriate problems. Through video, through secure message. How do doctors see it differently? What we value as patients, we don't value as a system, and making all those changes is difficult. On the other hand, we have been very successful in the Mid-Atlantic. Many of the challenges that other Kaiser Permanente regions have had, they were experiencing. They came under the leadership of Northern California, and now their quality is nation leading, now their services, and now they've doubled in membership over the past few years. It can get done. It's just simply difficult to accomplish.
Now, I know some people think, well, one possible solution to at least part of the healthcare problem is can we go around that? Can entrepreneurs and others create technologies to help us get around the behemoth healthcare system? Some of the really cool technologies are being invented right within a mile or two of where we're sitting, which is great. But I did read your book, which I recommend, by the way, to everybody. And I noticed that in that book, you're pretty pessimistic about most of those technologies. So 2 questions. Why are you pessimistic? And is there any particular technology, whether it's one of these ones trying to circumvent the system or something that's more dead center in the system, that you do think will be successful over the next decade?
So I'm very pro-technology. When I was in high school, I started programming computers, and I spent my whole life pushing technology. It's not the technology is the problem, it's the economic model back behind the technology that sits in place. What do I mean by that? In the Stanford Graduate School of Business, what I teach people is start with the problem you're trying to solve. Don't start with the technology. Someone comes up with a device that generates 1,000 EKGs. They want to send it to the doctor's office. The doctor has no desire to see 1,000 EKGs. It's not going to mean very much. But they start with the technology. You know, I often talk about the wearable, the Fitbit equivalents. You know, I don't know how many of you have Fitbits. The data shows that Fitbits do very, very little. And I only use that as a brand name. I don't mean that company per se. The wearable exercise. They only do 2 things. First of all, they tell you how far you went. And you can tell that on your, on your smartphone or a $5 plastic pedometer. And they tell you how well you slept last night. Now, first of all, you know how well you slept last night. And second of all, what are you going to do about it if you didn't sleep very well? But that's what they do. So why are they so successful? Because they solve a major problem. And by the way, as I said, what they found out is when you look at people trying to lose weight, you lose less weight using the devices than not. I'm not quite sure why, but that was a study that was published. They solve a major problem. It's called the December dilemma. It's Christmas or Hanukkah. There's someone you care a lot about. You want a present that costs between about $150 and $200. You want them to wear it all the time. It's got to look really, really cool. And they got to know how much you care. And it is exactly the right present. A third of the time, by 6 months, it's gone. By the way, for those of you who may be a little older, you may remember 1990s, it was the inline skates. 50% of inline skates never came out of the box after December 25th. All right? What's the problem you're trying to solve? That's the challenge of much of what I call the technology that glitters today. And I don't mean the Theranos of the world that was simply a scam. But even very, very good technology, what's the problem they're trying to solve? And very often, the problem is not solving the problem, it's generating the dollars. And the hype around the technology simply goes way beyond it. There are 3 technologies that I believe in very strongly. One technology is predictive analytics. And again, I have to use a little bit of Kaiser Permanente, and I apologize for that, but it's what I know best. So today, computer systems are looking at every patient who's in the hospital and predicting which patients tomorrow are going to be in the ICU. So that physicians can intervene today before tomorrow, because once your health status declines, even though you get better, your mortality goes up by a factor of 4. The same technology is being used to tell which patients are being sent over for the ED who's likely to come back tomorrow. Children born in the NICU who may have an infection. So predictive analytics, to me, I think are very, very, very powerful and become better so over time, assuming that doctors are willing to listen to the computer analyses and take the appropriate actions that are sitting in place. I think video will change American healthcare. I think as much as 30% of what we do today will be done through video. And we have a lot of good examples of that. Today, we have a stroke-trained neurologist who sees every patient who comes to any of the 20 emergency rooms in Northern California the minute they arrive. And the care now is starting that minute to make the important determination: do you need to give a very powerful clot-busting drug that also could kill you in the wrong circumstance? What's called door-to-needle time, the amount of time for the patient to arrive to get this clot-busting drug across the nation is over an hour. It's now under 30 minutes. Video allows that to happen. Similarly, in the Mid-Atlantic, there's a ED-trained physician on video available at all times, so that if a parent calls up with a problem about their child, they can do a consultation to determine, do you need to get out of bed, come to the ED and get the care, or can we actually solve it in a way that would be much easier for the family? And the third part to me, and I think it's really underappreciated, is what I call the comprehensive electronic health record. And I want to call that as comprehensive. It's not that single standalone thing in the physician's office that is for billing and claims. And it's not even what we call interoperability or interconnectivity, where a doctor can go into a system and find another doctor's information. They're not going to take the time. It's the fact that information is now presented to you. And when it's presented to you, it's very hard to ignore it. Context, shifting perception, changing behavior.
Great. Well, speaking of changing behavior, one of the great frustrations with our healthcare system is that sometimes we really do it right. The doctor makes the right diagnosis, gives the right prescription, tells the patient clearly, and the patient still doesn't do it, right? Doesn't take the drug, doesn't change the wound dressing at home, doesn't exercise, whatever it might be. So how can we improve patient adherence compliance? Someone says neurofeedback, virtual reality. We know you're not going to say Fitbit. What could be done to get us to do the right thing when we're actually have been told what to do?
I think often if patients don't follow the advice, there's a reason. I don't think patients want to harm their own health. It has to do with the context. Sometimes it's money. Sometimes they simply can't afford whatever they need to take to do. A lot of times it's time. Sometimes it's transportation. There's a lot of different reasons, but it's hard for me to imagine that people intentionally want to harm themselves. I think, though, having said that, and again, in the book, I talk about a lot about this perception issue. What we know is that things that are far away are less significant than things that are proximate to us. It's just the way perception works. I'm always amazed that people, when they get a colon cancer, will go to all lengths to figure out how to get treated when they could have avoided it in the first place if they had gotten the proper screening. I'm amazed that 1 out of 6 Americans today smoke. I mean, think about that. Smoking is the leading cause of cancer in the United States. And it's not just lung cancer, it's a variety of other cancers that sit in play. Not only is it the leading cause of cancer in the United States, but actually the state governments make money by killing people. I mean, imagine if someone had a product that had arsenic in it. We never would allow it to be sold. We certainly wouldn't tax it and make money off of it. That's cigarettes in the nation today. So I think there are reasons for most of these pieces when we do the wrong thing as individuals. I think some of it is the fact we've not educated patients well enough. Some of it is going to be language issues. I mean, there's so many different reasons that sit in play. But what we're learning very much is that the societal issues, and I talk a lot about this in Mistreated, are actually more powerful than the intervention. And some of the things are taboos. Patients who have had an adverse childhood experience have a much higher chance of developing chronic disease and having complications. Patients with intimate partner violence have a lot of complications that occur that medicine doesn't pay enough attention to, doesn't ask the right questions. People who have behavioral issues, psychological issues, we know have a much higher incidence of depression, and we know have higher incidence of chronic disease. So I think a lot of it goes back to the same thing about the broken system that sits in place. Doctors like to blame patients sometimes when they don't follow the advice. My belief is that occasionally the patient's to blame, but more of the times than not, again, it's the context of the explanation, it's the context of their life, and we have opportunities, starting with stopping smoking in the United States, to actually dramatically change the healthcare of Americans.
And what would be your quick suggestion for how best to try to change that context?
I'd write a book called Mistreated. I'd get every American to read it. I'd have everyone tell their friends who are not here tonight to read it. And hopefully in understanding all the things that they don't have, they would then start to look for the opportunities to get it and to demand it. I don't know any other way to do it than to start to provide the information to the patient and all of us, and I'm optimistic that that's going to be the outcome.
Right, great. I should thank the audience, too, for I'm not sure if you've made my job harder or easier or both. You gave me so many fantastic questions. There are many to choose from, but it's been tough choosing from them. And I think rather than ask one final question, because we're just about out of time, I'd like to give you, Dr. Pearl, an opportunity for any final reflections.
Sure. I started by talking about my dad, and let me finish by talking about my dad. So I told you that he had the problem from the pneumococcal septicemia, and that although he didn't die in the acute episode, he ended up developing complications. And he was in Florida at the time, and he had a major bleed into his brain. My brother and I got a phone call in the middle of the night and got on a plane the next morning. We flew to his hospital room. And there was a line of doctors out the door. The ENT doctor wanted to do a tracheostomy. The GI doc wanted to put the feeding tube in place. The neurosurgeon wanted to take out some more bones so his brain could expand. Then my brother and I, of course, looked at the x-rays and we said, my dad's not getting better. This is not the way that he wants to live the rest of his life. And we thanked them all, but we said no thank you. For the next 2.5 days, we never saw another physician. There's no CPT code for billing for compassion. There's no way in a fee-for-service world to get paid for sitting there and holding the hands of a family in grief. The American healthcare system is simply broken. And if we don't change it now, it's going to get worse and worse More people will die. More people will be mistreated. This is our chance. Change will be tough, but together we can do it. The book's written for the patients and all of us. I hope you enjoy it. Please let me know what you think. Thank you very much.
Great. Well, our thanks to Dr. Robert Pearl, who is the Executive Director and CEO of the Permanente Medical Group and author of the new book, Mistreated: Why We Think We're Getting Good Health Care and Why We Are Usually Wrong. We also want to thank our audiences here in San Francisco and on the internet, on the radio and television. I'd like to remind everyone that copies of Dr. Pearl's book are for sale, and he'll be pleased to sign them right after this program in the fireside room down the hall. I'm Mark Zitter of the Zedema Project, and now this meeting of the Commonwealth Club of California, the place where you're in the know, is adjourned.